Good evening, everybody. We welcome you all for this online event. On behalf of the Postgraduate Training Center, Deanship of Postgraduate Education, King Saud bin Abdulaziz University for Health Sciences, we would like to welcome you all. Today we have two distinguished presenters, Dr. Rani Milyani and Dr. Maram Al-Fawzan, who will be talking about the polypharmacy and deprescribing. I'm sure you'd have had a smooth registration process. If you do have any questions, please open on the question and answer session and post your questions, whether it is on the organization part or on the scientific part. Please do post it. And after the two presentations, we will attend to all your questions. On the scientific part, Dr. Rani and Dr. Maram will be addressing those science-related questions. So please do post your questions and we'll answer you. So now I would like to welcome our first presenter, Dr. Rani Milyani, on board. Dr. Rani?
Hi. Hello?
Hi, doctor.
Thank you so much. Hello, everyone. I hope everyone is doing well tonight. I'm Dr. Rani Milyani, an assistant consultant geriatrics, an American board certified geriatrician and internist. I work in the division of geriatrics at National Guard Hospital. I just want to share my presentation. Okay. One second. Okay, now it's working. So today I'm going to give a presentation about polypharmacy. So I'll be presenting the first part, which is polypharmacy, and then Dr. Maram Al-Fawzan is going to be talking about deprescription. My presentation will be covering the following: the definition of polypharmacy, the prevalence and risk factors, complications of polypharmacy, as well as the pharmacokinetics and aging. Also, we're going to be talking about the management of polypharmacy. And at the end, we'll be covering principles of prescribing. So please hold your question until the end of the presentation. As Deepa said, there will be 5 minutes for the Q&A, okay? So what is the definition of polypharmacy? There is unclear universal definition of polypharmacy, but some of the investigators and scientists, they would say it's multiple drug consumption and excessive drug use. Others would say it's unnecessary drug use. And some would say it's medication use without indication. But there is like a general definition that most physicians, and also by the WHO, the definition is a regular use of at least 5 medications. Still, there is a controversy regarding the duration of how long these medications should be used, and if that definition would include the use of over-the-counter medication or a herbal use. So how common is the polypharmacy? What is the prevalence? So in the United States, there was a cross-sectional study that was done from 1988 to 2010. They found that around 44 to 57% of older than 65 years take 5 or more medications per week. Also, 12% they take 10 or more medications per week. This is a figure that shows you that this is that 1988, since 1988 to 2010, you can see the proportion taking 5 medications, that this is the dark line, tripled from 12% to 39%. And this is a huge number. How about in Saudi Arabia? I found a study that was done in 2013. It was published in the Journal of Family and Community Medicine. It was done in the adult outpatient internal medicine clinics at King Abdulaziz Medical City, Riyadh. They defined polypharmacy as a 5 drugs use or more for at least 3 months. And they included in that definition the over-the-counter, topical, inhaled, and injectables. It's a cross-sectional observation and descriptive study. The population was adults who are 12 years or above. And they included at the end 766 patients, and they found that 89% had polypharmacy. This is a table that shows the most common prevalent disease with a higher odd ratio with polypharmacy. The most commons are dyslipidemia, hypertension, diabetes, and osteoarthritis. Also, there was another study that was done in 2017. It's a retrospective cross-sectional study. They included all adults who are aged 18 years and above. There was 17,000 patients in the study. Out of these 17,000, there was like around 4,000 patients who are 60 years and above. The results showed that 46% of adults were on 5 or more medications, and almost half of them using up to 4 medications. And again, the factors that are significantly associated with polypharmacy is age and disease load, and the number of prescribers. The last study that I'm going to talk about, it's a more of a comprehensive overview of polypharmacy. It was also done in Saudi Arabia. It was recently published in 2019. This is a retrospective cross-sectional study. They included and focused more on the patients who are 65 years of age and older. They included 3,000 patients, and the results shows 55% of patients have polypharmacy. The average was of 6 medications were prescribed for patients aged between 65 and 70 years of age. The definition in this study that they used for polypharmacy was if the patient is receiving 5 or more appropriate medications. The term appropriate means that they have not included any of the herbal use, over-the-counter, or any topical medication in their list. This is the figure that also shows the most common system that is involved with the prescribed appropriate medication. And again, it's the same as hypertension, like cardiovascular disease, hypertension, and dyslipidemia, and also like endocrinology, which is like more of a diabetes. So why pharmacotherapy is challenging these days? The reasons why is the use of multiple drug increases with increased morbidities or comorbidities, sorry. Especially in older age, many few patients that would come in with multiple chronic diseases. And this is a challenging because they might come with a long list of medication. Also, nutraceuticals are booming. Nutraceuticals are the herbal and nutritional supplements. Formulary change frequently. You have a medication that might change from topical to tablets and vice versa. Drugs over the counter, it's easy to find antihistamines over the counter, and if you are self-medicating, you'd probably be getting more medications over the counter. Increased risk for adverse drug events because of the metabolic changes with aging. And this is a topic that I'm going to be talking about extensively in this presentation. And drug-drug interaction, with increased number of medication in your list, there is a risk of the drug-drug interactions. So what are the risk factors for polypharmacy? The first thing is age. Age older than 62 is definitely a risk factor for polypharmacy. In fact, the prevalence of polypharmacy is expected to rise due to the global population aged over 65 years. It will be doubled from 8% since 2010 to 16% in 2050. And this is a huge number. The other thing is multimorbidities. It's associated with multiple, they can come to your clinic with multiple symptoms, impairments, and disabilities, and that's going to put them in a higher risk of prescribing and have more medications on their list. Also, multiple prescribers. Several medicines recommended by a number of specialists, and this is a challenging for the primary care physician when he gets his patient back from multiple physicians with a different type of medications on their list. Multiple pharmacies is a risk factor, as well as psychosocial. We did talk about self-medication. Those kind of patients can put them in a higher risk of polypharmacy. And also adverse drug events, reactions. It's not only about the risk factors about the patient or the way they practice, but also on the system level, there is a risk factor. A poorly updated medical records is a risk factor. For example, if you discharge a patient, if you discharge that patient and you want to discharge him and you want to change some of his medication and you discontinue one of his medication and you do not do a medication reconciliation, that same patient would go back to his primary care physician in the community. And because of automated refill services, he would just refill that medication that you discontinued, but you never updated his medical records. And that's a way or an example of a system level risk factor. If you have a good EMR, you can also have some tools that help you identify potential inappropriate medication use. Some tools that might help you in predicting if there is a drug-drug interaction or if this patient has some allergy to some medication that prevent a medical error. Now I'm going to be talking about the pharmacokinetics and aging. Why I'm focusing more with aging? Because older adults and 65 years of old, their kinetics might be different than any other younger patient. And also, it puts them in a higher risk because they have one or more chronic conditions and they might have a longer medication list. So pharmacokinetics and aging, I'm going to go over the absorption. This is the first step, and then distribution, metabolism, and excretion. The absorption in older adults, overall, with aging, it doesn't change the amount absorbed, but it might be slowed. And the peak serum concentration may be slowed or delayed. How is that so? It's three things that might affect the absorption. The route of administration. The route of administration, you might have a medication that's been given topical, like analgesia, or like some formulas like gels or transdermal patches. With aging, skin atrophies and becomes thinner and blood flow to the dermal layer may be reduced. This factor may alter the systemic absorption from topical products. This is way of how the route of administration might affect the absorption. And also, what is taken with the drug. You should always ask your patients, what are you taking with them? Are you taking any multivitamins? Are you taking calcium, magnesium? Those divalent cations can affect the absorption of many antibiotics. Also, comorbid illnesses. If the patient has some GI diseases that might affect the absorption of the medications. The second thing is the distribution. With aging, the body fat water composition will change. The body water will decrease, and that will lower the volume of distribution for hydrophilic drugs, for example, lithium. On the other hand, their fat stores will increase, and the higher volume of distribution for lipophilic drugs, for example, like trazodone and diazepam. That's going to give them a higher volume of distribution for those kind of drugs. Also, with aging, the muscle mass will decrease. So the total lean body mass will decrease, which can lower the volume of distribution of drugs that binds to muscles like digoxin. One of the things that is really important is the serum protein. This is a part of the distribution of some drugs. Some older adults, I'm not saying all of them, some of them who has some malnourishment, they don't eat well, they have chronic diseases that cause decrease in his albumin level or protein level, put them in a higher percentage of drug that is unbound, and it's more of an active form. And some of them is like warfarin. It puts them in a higher risk of toxic effect when the serum albumin level decreases. The third thing is that most of the medication, they will be metabolized through the liver. And with aging, the liver blood flow, the size and the mass will decrease. And because the decrease in the mass and the size and the blood flow, that will decrease the hepatic metabolism, which is done through the cytochrome P450. And typically will decrease from 30 to 40%. Also keep in mind that some medication or that enzyme can be induced by some medications like rifampin, phenytoin, carbamazepine, and it also can be inhibited by other medications like macrolides, antibiotics, and grapefruit juice. Other factors affect metabolism as age and some ethnicities can affect metabolism. But also that things that doesn't come in mind, that hepatic congestion from heart failure can affect the metabolism of the liver. It reduces metabolisms, for example, of warfarin. Also, a lot of people don't think about smoking. It can sometimes affect the clearance or increase the clearance of some of the medication. So always ask your patients about, do you smoke or do you drink? The last one is the excretion. Most of the drugs will be eliminated through the kidneys. And most of the older adults, they will have multiple comorbidities, and it might affect the kidney function and reduces the elimination stage. The message that I want to send to the participants for tonight is serum creatinine does not reflect creatinine clearance in older adults. The reason why is that the lean body mass will decrease, and that's the source of creatinine. And if that's decreased, then the lower creatinine production and then lower glomerular filtration rate. But creatinine itself will not reflect the creatinine clearance in older adults. It will stay normal and mask the change in the creatinine clearance. So how can we know, or what should we look for? There is two ways to determine creatinine clearance. Whether you measure it by 24-hour urine collection and it's time consuming, or you do the 8-hour collection, maybe accurate but not widely accepted. Or you can just estimate it with the GFR by doing the calculation of Cockcroft-Gault equation. But just keep in mind, creatinine will not reflect the real creatinine clearance in older adults. This is a nice picture. I just want to share. It shows the changes of hepatic metabolism and albumin and renal function across all ages. But what really concerns me tonight is I'm looking on the adults and elderly. If you can look at older adults, most of them, they have almost no changes. But still, keep in mind, you might get a younger adult and he might have a lot of renal function, kidney impairment. He might have heart failure. Still, he's maybe in his 40s, but still he might have a lot of comorbidities that puts him in a higher risk of renal function impairment or hepatic metabolism changes. But if you look at the elder adults, everything almost decreased. And this is why I highlighted tonight that regarding the pharmacokinetics and aging. So what is the complications of polypharmacy? The complications of polypharmacy, it goes into two main things. The patient himself, it's a complication on the patient, and there is a complication on the healthcare system. The complications on the patient is that it increases risk of geriatric syndromes, like cognitive impairment, falls, hip fractures, delirium, urinary incontinence, and also decreased quality of life. How so is if you have a patient with a frequent dosing, that might affect his daily routine, his daily, if he's going to take something in the morning and then in the middle of the day and then at night, that might affect his daily routine if he wants to go out and have a good life. That might affect or decrease his quality of life. Also, poor adherence. The more you give medication, the less that the patient will let he be compliant. Drug-drug interaction and adverse drug reaction, which I'll be talking more in details later, and also increased mortality. But how about the healthcare system complications? First is it does increase the cost and burden on the healthcare system. And I think it's not only increased cost on the healthcare system, but it can also affect the patient himself in terms of cost. If the patient doesn't have a health insurance and he has a long list of medication and he needs to pay out of pocket, that's a burden on the patient himself. Also, it decreased physician workflow and quality of care. The quality of care and the productivity of the physician when he admits a patient with a long list, or even in the outpatient clinic, that he needs to double check his medication list, that's gonna impair his workflow and the quality of care. Also, it might affect the healthcare system in terms of medication errors. In the United States, it's estimated that healthcare medication error costs around 42 billion annually from medication error by itself. This is a table. It shows the geriatric syndromes that are associated with polypharmacy, and these are the most complications that you might face. And the most common thing that we face in the inpatient and we get consults about is delirium. It's one of the most common things in the inpatient unit. And it shows you some specific drug classes that can cause delirium, like anticholinergics, benzos, steroids, H2 receptor antagonists, or sedatives. Those medications that increase the risk of delirium. Also, one of the geriatric syndromes is falls, and one of the most simple examples that I can give, and everyone has seen, is you have an older adult who's been taking multiple hypotensive medication, antihypertensive medication, and then he became orthostatic, and he falls. He gets his hip fractured. He goes inpatient and hospitalized. He gets disability. He gets through surgery, and his mortality increase. And this is how complications can happen because of polypharmacy. Also, one of the syndromes is urinary incontinence, and you can see anticholinesterase inhibitors can cause urinary incontinence. Dizziness, orthostasis, as previously I was talking about, and weight loss, also constipation. Some of the calcium channel blockers can cause constipation. So these are the most common geriatric syndromes that might happen because of the complications of polypharmacy. Now I'm going to be talking about the adverse drug events. The definition is an injury resulting from the use of a drug, and adverse drug reaction is a type of ADE, and it's referring to harm directly caused by a drug that at a usual dosage. So a patient, you prescribe a drug to a patient, and he comes the next visit, and he talks about an adverse drug reaction. That's on a regular dose, the usual dose. I'm not talking about overdose, the usual dosage. How common is ADEs in Saudi Arabia? There was a study that looked into ADEs in Saudi Arabia, and it's a prospective cohort study. They followed 4,000 patients from admission to discharge. They analyzed around 3,000 patients, and the mean age of that study was 43 years. And they found almost half, like 1,500 patients identified with incidents during the admission. And the incidence was around 6.1 per 100 admission and 7.9 per 1,000 patient days. And the most common places or units where ADEs were common, as you can see, the ICU with the 60%. And then followed by medical with the 27%, and then the surgical units with 11%. How severe are these ADEs? They classify it as significant, serious, life-threatening, and fatal. And the majority were, or half of the ADEs were significant with the 52%, and then around 35% were serious. And then life-threatening, 9%, and around 1% are fatal. So adverse drug events commonly, or sometimes, they might lead to something called the prescribing cascade. The prescribing cascade refers to the misdiagnosis of a new symptoms caused by a drug as a new disease requiring a prescription. So if you go through this is drug 1. You have a patient come in, complaining for something, and you prescribe drug 1. And then in the next visit, he comes with an adverse drug event that are interpreted as a new medical condition, for which you start another drug. And then the next follow-up, he come in with an ADE, as an interpreted as a new medical condition and so on. This is a case regarding the prescription cascade. It's a 55-year-old male presented to your clinic with a knee pain. What do is you prescribe him NSAIDs. You follow up, he come in, you found that he has an elevated blood pressure. What you do is you prescribe him a calcium channel blocker. Then the next visit, he come in with a lower lymphedema. What you think is maybe it might be heart failure. So what do is prescribe him diuretics. While in fact, this is all regarding the elevated blood pressure is because of the NSAIDs adverse drug events. And this is a classical example of a feedback loop, as a cause of the problem is assumed to be a physiological state, if the patient rather than the medicine and the patient is taken. So this cycle is a vicious cycle can start and can continue for a long duration. So you always have to keep in mind when you start a medication that when you follow up with the patient that he might come in with an adverse drug event. It's not a new disease. So now, what is the management of polypharmacy? The management of polypharmacy is a multidisciplinary approach. It involves the nurse, healthcare system, pharmacist, and the physician. The role of the nurse, I think, is a really important role because, the nurse can pick up some side effects, some drug-drug interactions in the inpatient units because she sees the patient the most, more than the physician himself. The healthcare system, we did talk about tools that we can implement. And then I'm going to talk more in details about the physician and the pharmacist. So what is the physician role? So the physician role, the first thing that he needs to do, and the most simple thing, is to complete a medication history. He should ask about allergies, over-the-counter drugs, nutritional supplements, tobacco, alcohol, caffeine, or if he has been into other subspecialties, or if he got any prescription from other prescriber. A detailed, complete medication history is a key. Also, the second thing is matching. What do I mean about matching? Matching is when you see a medication list, is to think, this medication, what is the indication for? Do I have an indication means if he's on antihypertensive medication, is it a diagnosis of hypertension? Or it's just a medication that was thrown on the patient without a clinical diagnosis? Also, you look for the side effects. You ask your patient, do you have any side effects from any of your medication? And you look for adherence. You ask about the compliance, and I'm going to talk more about this. Always reconcile medications, whether in the inpatient or outpatient practices. You assess the risk and benefits. Always, when you have a patient in your clinic, assess the risk and benefits, especially with older population. You assess, is this the benefits outweigh the risk, or the risk outweighs the benefit, and does he really need to be on this medication? And at the end, your role is to either deprescribe, prescribe, or even continue the same medication. Regarding adherence, I mean, in older adults, it might be as high as 50%. And the elements or the dimensions, the 5 dimensions of compliance or adherence in any patients are: first, social economic. Patients might have some language barriers, or maybe they might have an unstable living environment, or maybe we talked about health insurance, the medication cost. They can't afford it. They can't buy it. Therefore, they're not going to take it. Second is the healthcare system. Sometimes there is lack of continuity between the patient and the provider, or there is some restricted formulas that the hospital cannot provide to the patient. Third is condition related. An example of a simple condition related is depression. You might have a patient who's depressed and he would say, well, I'm so depressed, I just don't want to take my medication. And this is one of the things that can affect compliance. Fourth is therapy-related. Therapy-related is the complexity of medication regimen. Sometimes it's too complex that the patient cannot adhere to, or it's patient-related. Sometimes patients, they don't know why they're taking this medication or what is the reason of taking it. Is it really important to take it? So education is a key in adherence. How to improve it is to identify barriers. I always ask my patient, instead of asking him, do you take this medication? He might be ashamed to say no, but instead I would ask, do you find difficulties in taking your medications? And then he might open up and say, well, the frequency is driving me crazy. Also provide education. Give education why you're giving it. Is it important and for what? Simplify the regimen. Don't make it too complicated. Also, telephone call reminders like calendars or interactive technology might help in the compliance and adherence. And if you have a patient with cognitive impairment, always involve a caregiver. And you can utilize your weekly pill box as a reminder or to help you or be organized. The pharmacist role, the pharmacist has a very important role. They perform discharge counseling, assess drug-drug interaction, prevent medication errors, and monitor some adverse events. They have a very positive role to play, and they can intervene to reduce if necessary. What is the principle of prescribing? The basics. The basics of any prescription is to start with a low dose, titrate upward slowly, keep it short, avoid starting 2 drugs at the same time. And keep it simple. Means that don't make it complicated with too many dosing, like frequency during the day. And always, I would say, when you start a new drug, ask these questions. Is this medication necessary? What are the therapeutic endpoints? Again, the benefits and risk. Is this an ADE? Is this another drug effect? Or could one drug be used to treat 2 conditions? And this is going to simplify your regimen. And also, could it interact? This is the part where you look for drug-drug interaction. And at the end, does patient know what is it for, how to take it, and what to look for a side effect? This is where you come in and educate your patient. This is an important message that you do not prescribe a medication without conducting a drug regimen review. It's very important. There are some tools that I would talk about so quick as how to decrease polypharmacy. There is no yet validated like a superior tool to decrease polypharmacy, but I found these tools that are really important and they help to decrease the polypharmacy. The Beers criteria and also stop and start. Beers criteria is a list that they list the inappropriate medication in older adults and improves drug selection. It was created by Beers, a geriatrician. It was first published by the American Geriatric Society in 1989 and last updated in 2019. And it's all recommendation evidence-based. They categorize the recommendation into drugs to avoid in patients with specific disease or syndromes, drugs to use with caution. They give you recommendations what to use with caution, and selected drugs whose dose should be adjusted based on kidney function. And the last category is selected drug-drug interaction. This is just like examples to show you what is Beers criteria is, but it's you can find it in the American Geriatric Society website. This is which shows you the what to give and what to avoid with reduced creatinine clearance. One of them is duloxetine. If it's less than 30, you should definitely avoid. And the rest, if let's say gabapentin, if it's less than 60, then you try to reduce the dose. And also that's part of the pharmacist where he come in and help you with reducing the dose per creatinine clearance. And this is another example where it shows like per medication, like first generation antihistamine, and why you should avoid it because it's highly anticholinergic. And it gives you the evidence base if it's strong or moderate. It's a very useful tool. The stop and start criteria, they're used together, by the way. You can use them, they're used together. So the stop is the screening tool for of older person prescription. Is that where you stop medication? And the tool gives you an idea like based on system. Like let's say the musculoskeletal system here, it gives you a recommendation like NSAIDs, with moderate, severe hypertension should not be used. That's where you go stop using them. And then you look for alternatives like START tool, where you screen to alert to the right treatment. Like for example, you have a patient with osteoporosis, it recommends that you use calcium and vitamin D as a supplement in those kind of patients. It's also a useful tool. Now I'm just going to give a quick case on how we do a medication review and how we match and look for the side effects. You have Grandpa, he's a 70-year-old white man with a past medical history of diabetes for 15 years, AFib, atrial fibrillation, hypertension, and hyperlipidemia. Mr. Carl, past medical, the rest of his history is non-significant. His exam with vital signs that it shows 120/82, heart rate of 70, lungs are clear, abdomen is soft, lower extremity with 2 lower lymphedema, and decreased pulses both bilaterally. In terms of his labs, A1C is 8.2, LDL 126, triglyceride 180, potassium 45, potassium 5.3, and creatinine 1.1, and GFR 16. His medication list includes 13 medication, starting with lisinopril, pioglitazone, metformin twice daily, warfarin per INR, simvastatin, rosiglitazone, atenolol, glyburide twice daily, diltiazem, potassium, Lasix, digoxin, and pantoprazole. So the way I would look into this patient is how I'm going to be matching. It's a long list of medications, so I have to match. If I look at his diagnosis of diabetes, he's on 4 medications of diabetes. TZDs, 2 of them, and metformin and glyburide. And most of them, they are doses twice daily. For hypertension, I would say lisinopril, atenolol, diltiazem, and Lasix. For the dyslipidemia is simvastatin. For AFib is warfarin. And some extra medication, miscellaneous, that I would say is pantoprazole and potassium chloride. So in this kind of patient, this is the way I match in my mind. I don't need a paper and pen. I just need like how to match the medication with the indication or the proper diagnosis. Always check for appropriateness. Always question yourself. So why furosemide? Why is this patient in furosemide? I haven't seen any diagnosis of heart failure. Was it given because the patient had a lower lymphedema? Or is that lower lymphedema because of the calcium channel blocker or the TZDs that been used with him? Always question that. Why potassium? His potassium is 5.2. It's actually a little bit high. Why I'm giving it to the patient? And maybe I should consider stopping it. And then why is this patient on 2 TZDs together being used? This is a duplicate therapy with an A1C of 8 with his target and age. It would even target for lower than that. And why is this patient on pantoprazole? PPI, there was no indication and no complaint. The last thing that I would question is why 3 antihypertensive medication when his blood pressure was in the 120s and the target for older adults is 150 and less. So always check for the appropriateness and question, why is this patient taking this? Is this would benefit him? Is this gonna harm him? And risk and benefit and side effect. The last thing that I think is an important thing to mention in my presentation is dietary and herbal preparation. The supplements are vitamin and minerals. The herbal preparations are like, I would just give examples like ginkgo biloba, garlic, St. John's wort, kava, or valerian roots. Older adults in a study that was done and published in 2005 in the United States showed that there was an increase from 14% in 1998 to 63% in 2010 of herbal use among older adults. And this is a huge increase. And probably because of the advertisement and also because some of the friends would have been recommended some herbal to that patient. But keep in mind, please, that it can interact with the prescribed medication and lead to serious adverse events. One of the examples is ginkgo. If you give it with a patient who's been taking warfarin, that might increase the risk of bleed. So this is an important thing that you please ask your patient about all preparation, not just the prescription drugs. In my conclusion, I just want to give some simple messages or like a take-home message. Polypharmacy is a major medical problem. Please perform an extensive medication review. And any new symptoms is a drug adverse event until proven otherwise. And always when you try to prescribe, keep it short and simple. And that's it. Thank you so much, everyone. Thank you for listening. And now I'll ask Dr. Maram Al-Fawzan to join.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everybody. I would like to thank Dr. Miliani for this very nice, extensive presentation that I really enjoyed. And I'll share my slides with you about deprescribing. So I'll be talking about deprescribing, which is a relatively new term
Dr. Maram, we are not able to see your slides. Dr. Maram, we are not able to see your slides.
Is it fine now?
Excellent.
Can you see it now?
Yeah.
Okay. So we'll be talking about definition of deprescribing, goals of this deprescribing, which patient we should target, which medication, and approach to deprescribing, barriers, and tools used for or helping for deprescribing. I'll start with a saying of the father of modern medicine, Dr. William Osler, who said one of the first duties of the physician is to educate the masses not to take medicine. And as we all agree, all medications are potentially harmful. If you want to define deprescribing, it's the process of medication withdrawal supervised by a healthcare professional with the goal of managing either polypharmacy or just improving the outcomes. So it is proactive to prevent future problems and can be framed as a good clinical practice. One of the main goals of deprescribing is reducing medication burdens. So when we have careful medication review and aggressive discontinuation, that can reduce the number of medication in up to 39%. Also, it can reduce potentially inappropriate medications, such as the one in the Beers list, for example, in up to 30 to 60% or more. Also, it will help improve compliance to remaining medication, improve quality of life, and decrease the health system utilization. As sometimes if you prescribe a medication, you need to follow up, you need to do some investigation also. And if we focus on in geriatric group or a controlled setting of the nursing home, where they can do deprescribing programs, have been shown to reduce fall risk by 24%. Also, in nursing home setting, discontinuation of benzodiazepine has been shown to improve cognitive function in their residents. Again, in the same population, there was a reduction of hospitalization by 36% and a reduction of death by 26 to 38%. Most importantly, it will, of course, reduce cost significantly. So which patient should we target for deprescribing? Many studies shown that geriatric patients are the most patients that can benefit from DP. But also there is a need for palliative patients to where the goal of care is different at the end of life. To prescribe deprescribe medications, especially for preventive medication or life-prolonging medication. Or we can do it for any patient that is using a medication that is ineffective or have a high risk of side effects or harm. So patient characteristic, patients of polypharmacy are the higher population that will benefit from deprescribing to avoid the side effects and the burden of having a lot of medication, patients with multimorbidity, patient with renal impairment, patient, as Dr. Miliani mentioned, with multiple prescribers or fragmented care, or in cases of transition of care, like patients going out of the hospital to the community or going to long-term care where the goal of care is changing. Or simply if the patient is not compliant to this medication. And medication characteristic, mainly we target potentially inappropriate medications or high-risk medication, opioids, benzodiazepines, medication with high alert quotient. So how we approach deprescribing? It is a multi-stage process. It is mainly patient-centered, and it needs documentation and communication with different healthcare professionals. We can divide it to 3 phases. So the first phase in reviewing the medication and engaging the patient. The second stage is deciding which medication we will prescribe. And the other last stage is planning how we will stop this medication or reduce it, implementation, monitoring, and to continue follow-up. And I will speak about each phase alone. So phase 1, so complete list of all regular PRN medication, over-the-counter and complementary medications, dosing, frequency, duration, indication, patient experience, was it effective, not effective, the side effects, what they hate about it, and if they are really using it or compliant. Also reviewing the patient goal of care and preference and values, and consider the patient overall susceptibility to drug-induced harms. If this patient is an elderly with many comorbidities, with dementia, with a terminal disease, the level of function also will be make you wonder if the patient will benefit from this medication or no. Also, connection with other healthcare professionals who may need to be consulted or could assist with the process, either a specialist, a cardiologist, neurologist, or a clinical pharmacist, or even his primary doctor. And it always, deprescribing need to be framed as not giving up on you or taking something of value from the patient. This is actually the opposite. It is for optimizing the care. After that, we need to identify and decide which drug to deprescribe. And we always think about why should this medicine be stopped and how, and will there is how it will be withdrawn or monitored. And we should focus on medications that have no valid or current indication, like PPI after discharge from proton pump inhibitors after discharge from hospital, which was given for prophylaxis, or causing or contributing to a known or suspected adverse drug reaction, like a patient with lower limb edema after starting a calcium channel blocker. Also, generally high risk in this population, like giving antipsychotics in a dementia patients, or medication that is ineffective. Patient like on pregabalin for neuropathic pain, and he's not gaining any benefit, and he still continue to take this medication. Or if a medication is used for preventive indication in a patient with a life-limiting illness, like giving a statin in end of life, or and Alzheimer's severe stages, and they're still in bisphosphonate, or causing an unacceptable treatment burden, as some patients that will not tolerate like injections daily or multiple injections for that reason. Also, a medication which are causing harm, of course, should be targeted, stopped first, or greater concern to the patient. And always we need to have a shared decision making in deciding which medication to be stopped or reduced, in order to ensure that the patient opinion and goal are recognized. And for sure, this will increase patient satisfaction, better adherence to the treatment plan, and greater treatment engagement. Then we go to the last phase, where we start planning, implementing, and monitoring and follow-up of these changes. So it's better to stop one drug at a time, which is will encourage patient willingness and enable appropriate monitoring. Also, deprescribing should be considered always as a trial. So this will reassure our patients that we can anytime go back to your prescription medication. Also, tapering is recommended, especially when there is a risk of adverse drug withdrawal reaction. I will talk about it in the next slide. And always identify the lowest effective dose to minimize the return of the symptoms if they occur, and encourage the patient to have the medication stopped. And the general rule of thumb is to reduce the dose by 50% every 2 to 4 weeks. This is a rough rule, or really a general rule, with monitoring at each dose reduction also. And even after stopping the medication 2 to 4 weeks. And another idea is to step down through available doses formulation, which is easier to the patient. So the adverse drug withdrawal reaction, some medication will have more side effects if it's stopped abruptly, either because of their long half-life or upgrade or downgrade of receptor, and it will take some time to redistribute. A good example is opioids, steroid, antidepressants, and benzodiazepine, which I think need good training and stepwise approach in clearing these medications. Another medication that is need tapering. I think a lot of patients, especially elderly, are using it. For example, alpha-2 agonists, if we stop it abruptly, we expect to have rebound hypertension, tachycardia, agitation, headache. Beta blockers also with abrupt stopping expected to have withdrawal symptoms. So it is recommended usually to taper slowly in 2 weeks. Also, a patient and their caregiver and family should be aware what to self-monitor for. So they should be aware of these possible symptoms that may occur. And all of this need to be documented, the plan of deprescribing and any outcome that happened, and whether the deprescribing should be reattempted again or a trial was done and it was not successful. And also, at all times, we need to ensure ongoing communication with the patient and all relative healthcare professionals. This is just to summarize what we said. So after reviewing the medication and we decide which medication we want to stop, we start a discussion with the patient or family regarding this deprescribing, and again the agreement. Then we see if it needs tapering, we start the tapering, or just discontinue the medication immediately. And it is a cycle, so it needs to be continuously reviewed in each visit if there's time. Practical strategies in the approach to deprescribing is to set aside separate visit to focus on the medication review, especially with patients with polypharmacy or with high-risk medications like opioids or benzodiazepine, which need really good time and education in stopping that. Also, use of the expertise and services of multidisciplinary team. If we need a specialist opinion regarding stopping a medication, if we need a clinical pharmacist to help, or even a practice nurse that has follow-up even for blood pressure monitoring or just encouraging. And also, deprescribing will not be conducted in one visit. It's really a process which is multi-stage and need a lot of talking, explanation, and education. And the use of patient educational material will be very helpful if it's available. Now we'll talk about barriers. One of the presumed barriers is that the patient and family might be reluctant. And surprisingly, in elderly, more than 90% of patients are willing to stop medication if their doctor just say it's possible. Other very important barrier is the lack of evidence. And we can see many of the guidelines will direct us when to start this medication, but rarely they will say at what time you will stop it. So this is really clinical judgment when weighing the lack of evidence, the benefit of the continuing this medicine or no. Also lack of experience. So it is really challenging to decide which medication is more problematic in this medication. For example, the case that Dr. Miliani showed. So sometimes you get confused. So where should I start? Other barrier is also the communication. I find it really very important barrier. Communication with other healthcare professional. As us as clinicians may be hesitant to stop medication that was started by a specialist or another doctor, and they feel that even sometimes ethically is that appropriate, and are we breaking the professional hierarchy while doing that? And the best solution for that is direct communication when it's possible. And if communication is not forthcoming, clinicians should not hesitate to take the initiative and stop medication when they are clearly inappropriate or causing more harm than benefit with proper documentation. Another barrier is the medical culture. So we starting medication is really familiar and consider this is the positive action, while the deprescribing is less familiar to us and may be considered as low priority or as like withdrawing the care. Also, clinical inertia, or when you are on a medication, just continue. Why to re-evaluate? So it's just a continuation along a path of treatment without re-evaluation, which is also common in the medical culture and will discourage deprescribing. One of the very important barriers is limited time. Deprescribing is a really complex process and will require follow-up, education, discussion. And I found a study done in Saudi Arabia focusing on knowledge and willingness of physicians about deprescribing among older adults, which was published in 2018 by Rashid et al. And similarly, they find the same thing, that they lack the knowing what's the term or the process of deprescribing, and patient follow-up with multiple hospitals, receive many medications from multiple healthcare providers, patient comorbidities, risk or fear of conflict that might happen with the pharmacist or between physicians, or feeling uncomfortable to not sure about their decision or uncertainty, discrepancy between the guidelines, also lack of documentation and communication. So sometimes we don't really know if there is an indication for this medication or no. Was it tried? Was there a trial of stopping it or no? Lack of time for sure, and difficulty in practicing deprescribing, sometimes patient resistance and or acceptance, and lack of a specific doctor. So who's really the primary doctor of this patient? I'll talk about some special groups of patients in deprescribing, like deprescribing in hospitalized patients, where it appears that hospitalization is potentially a good opportunity, as you have a complete medication history, reconciliation performed on admission, there is an access for multidisciplinary team, and there is ability to follow short-term follow-up or monitoring. But the limitation usually is the duration of admission. Sometimes it's short to titrate, and deprescribing is likely to be lower priority than the acute reason of admission. How to make use of that? Communication with the primary doctor generally is very advisable before changing any long-term medication. And I think the discharge summary should be very detailed and clear any changes that was made and what's the long-term plan. Also, the post-hospitalization visit is very important to stop medication that was started on admission for the acute illness, or if it will need to be continued. Other special group is the people with nearing the end of life or palliative care. So at this time, we often prioritize controlling symptoms over the life-preserving therapy, and there is less opportunity to benefit from therapies that prevent, as we mentioned, diseases over the long time. So you will not give like statins or bisphosphonates or anything with long-term benefits. And some medication which we try to stop in other regular patients, here we sometimes will prescribe like benzodiazepine, as the goal of care is really comfort and support, and might be very beneficial in these patients. I'll mention some tools and networks that I came across. I find the Canadian deep prescribing networks very useful material that I will show you some. There is the US also deep prescribing research network, the English deep prescribing network, and the Australian. And they focus on educating the community, patients, physicians, and help them, like it's like tools to help you, assist you if you want to decide to stop medication. This is something for patients. So you have to think, do I still need this medication? If I'm having two medication, what's the possible harms, falls, fracture, admission, memory problems? And to ask themselves these 5 questions: why I'm taking this medication? Are there potential benefits and harm of this medication? Can it affect my memory or cause me to fall? Can I stop or reduce this dose? How do I follow up when if I stop it? So this is again one of well studied, I think, in deep prescribing is the proton pump inhibitor. So this is the Canadian Deep Prescribing Organization, and this is a patient pamphlet where they show, they educate the patient about which types of proton pump inhibitors, why we should stop it, and the possible side effects, lowering vitamin B12, bone fracture, pneumonia, increasing C. difficile infections, and when to continue indefinitely, how safely to reduce it, and how to monitor if we reduce it, what you expected symptoms, what other ways to relieve your heartburn or reflexes and reflux, and this is the personalized agreeable. Another thing also they have is the decision helping tool. So this is a decision making tool that help patients make decision. So after you give them all the information, you want them to know that, do they feel sure that this is the best choice for them? Do they understand the benefit risk of each option? Are they clear about the benefit of risk matter most for them? So individualized patient-centered care, and do they have enough support if they make any decision? And then they would decide what they want. They want to continue, they want to try to take a lower dose, they want to stop it and use on demand, they are not sure. This is a nice algorithm, I find it, for deep prescribing PPI. So just dividing patients that need to be continued on PPIs, while other patients like treated H. pylori or just mild GERD after prolonged treatment. So this is where it's recommended to prescribe, and it is strong evidence. And there is 2 ways they show for deep prescribing, either decreasing to a lower dose or stop and use on demand. Then to monitor in 4 to 12 weeks for symptoms, and to advise to use non-drug approach, avoiding meals at bedtime or elevation of the head of the bed, or even using sometimes over-the-counter the anti-acids or H2 blockers. Another medication that even Dr. Rani mentioned about antihypertensive drugs, especially in elderly, and this is I found it in JAMA in May 2020, which is a randomized trial which called Optimize, which optimizing treatment of mild systolic hypertension in the elderly, where they take 500 plus participants age 80 years or more, who are taking 2 or more antihypertensive, and they divide them to control group that they continue their same multi-medication for antihypertensive, and they have the other intervention group where they took some of the antihypertensive medications, and they follow up for 12 weeks, and they find that the percentage with controlled systolic blood pressure was almost equal, and they observed a non-inferiority margin. So they recommended that a longer term study should be done to know really if there is no harm for a long-term use of this. Another available tool that helps decision making for physician is medstopper.com, where you can just use if the patient is frail or no, and just write the generic or the brand name, and it will appear for you the stopping priority of this medication. If it's red, it's a high priority, green is the lowest, writing the category and how suggested to tapering approach and what possible symptoms if you stop it, and it shows the peers and stop criteria mentioned before. Again, it's really very simple, very helpful tool that you can go back when you're not sure. And it guides you step by step. So my summary is just less is more in medication or in polypharmacy. And this is just if someone is interested to update himself later about deprescribing, there will be a virtual meeting in October from the US Deprescribing Research Network. Thank you. And we're happy to have, if you have any questions.
Deepa, do we have any questions? Anyone have a question? Can you post it in the Q&A?
There are no questions. Probably they can post the questions now, or they can email us. So if you want to.
So thank you, Dr. Maram. It was a nice presentation. If any of the participants has a questions, our emails are posted, and I think Deepa would be able to help spread our emails if anyone needs it. Thank you all for. Is that you, Deepa? Events? Is that the link?
Yes,
okay.
That's the event. That's the link for the participants to print their certificates after filling the course evaluation.
Okay. Thank you all. Thank you so much, Deepa, for organizing this, and thank you, Dr. Maram.
Thank you. You were wonderful rocking stars, Dr. Maram and Dr. Naneem. Wonderful.
Thank you so much.
That's great.
Thank you very much. Thank you, participants, for attending. Thank you all. Good night.
Thank you. Good night, everybody.
Good night.
Yeah, sorry for this. It just says they disconnected from internet. So we reach to the administrative control. I think this is what you hear last. And the most important thing here, as we said, that the dentist and the healthcare worker, the dental clinic need to wear the face mask all the time. We have to limit clinical care to be one patient at a time. As I said before, priorities, urgency and urgent thing need to be also looked at. Avoid resource-generating procedure, but in case if there is any resource-generating procedure, we have to advise for four-handed dentistry. So another guy will help during this, and we have to use a high evacuation suction and also use the dam. And this all, the dental dams, this all will decrease, you know, the aerosols. The other thing also we need to consider the pre-procedures mouth rinsing. Some engineering control, most of this engineering control related to using HEPA filters, either portable, using the high, changing the HVAC system to have a negative or semi-negative, either even if it's not, you know, negative pressure room, but at least negative ventilation. So most of the air and the air change per hour it will be increased. I know it will be difficult to change all our, you know, dental clinic to have it as a negative pressure room, but at least if it's not, you know, a negative pressure room, and we cannot do it, at least at a negative ventilation, or to use a portable HEPA filter near to the patient head during the dental procedure. The personal protective equipment, we advise for surgical mask, eye protection and face shield, and also the gown with protective clothing during procedures, especially if there is any splashes. And during AGPs or aerosol-generating procedures, using the N95 respirator or copper, which is the positive airway, hoods and that, you know, protect those who are not, you know, fit tested. Some of the environmental infection control, and this is also as a general rule, is not something new. Some facilities, they have more than one chair at that place. Let's say this is an open area with many dental chairs, and this is actually, I don't think in our area we have them. Usually the dental chairs, they are assigned to one room, so each room have one dental chair. But if there is an open area where we have a lot of dental chairs at that area, we have to maintain 6 feet, you know, spacing among them. And this is very also important environmental, you know, control steps. Other, you know, all related environmental infection control is mainly dedicated to disinfecting and the high touchable areas, the chairs, the room, and also the things that we are using in instruments, and also to give, you know, a good time between patients, not less than 15 minutes, to ensure that the air change per hour or the room airs change, and also ensure that we give the staff appropriate time to do the cleaning of the room and all the equipment. Sterilization and disinfection of patients' care items. This already mentioned by my colleague Hisham. There is no specific changes. It's the usual protocol when we are dealing with respiratory pathogens. We need to look to every area inside the room, especially the high touchable area. With that, I reach to my end of my talk, and mainly what we covered here with the dental clinic precautions. We need to be sure that the staff, they are aware about their risk, and also they know how to use the PPEs, and the PPEs, they are available. Doing the triaging, having the patient on time, and trying to minimize using the waiting area. The waiting area need to be prepared to have good spacing, and also without any magazines or toys or anything there. And whenever we have any result generating procedures during the procedure itself, we have to depend on other equipments, other people to help us to minimize and to be away from the head. The negative pressure rooms, we cannot maintain it inside the dental clinic, but at least negative ventilation if it's possible, or to have a portable HEPA filter. Other related, environmental health or environmental infection control, it's just a routine, but generally speaking, we have to give a good time between patients to give the enough period for cleaning and disinfections, and also for the room to air to be changed between patients. This is the end of my talk, and I'm sorry about what happened. I hope it was very helpful. Thank you very much. I'll just trying to take this out. This out. So this is the end of our session for today, but we'll go before that to I'm trying actually to connect our colleague from the GCC Health Council. I don't know if they are able to come with us or not. Are they aware? Are they around? Our colleague from GCC Health Council?
No, doctor, they could not log in.
They couldn't? Okay, so we'll take maybe one or two questions, then we'll close if there is any other important thing. So some of the questions here from mainly, I think, towards medications, some of them regarding medications. So maybe this for Dr. Noor. Dr. Noor, are you around?
Yes, Dr. Majid, I'm here.
Yeah, so here we're talking about the recovery trial. Did you use any other steroid other than dexamethasone?
I believe they used, I think there was a small number of pregnant patients, I think like less than 10 patients where they, obviously they wouldn't use dex, they used prednisone. I think that was the only one. And it depends on what part of the recovery trial they're talking about. So if this is the dexamethasone arm, then they only use dexamethasone. And in general, I believe even in the hydroxychloroquine arm, they only, if they did end up using in the follow-up period steroids, it was mostly dexamethasone.
Okay, but there is a small group that use different than dexamethasone, but they are very minimal, and that's recovery trial. They're not a lot. But when you look to the recommendation, they are okay about to use any steroid with equivalent, dosing, equivalent dosing to 6 milligram of dexamethasone.
Okay.
Am I right?
If the question is if can you use other steroids, if not available, I would say yes. I mean, of course, the dexamethasone has mineral corticoid. It's a bit different, but yes, I would use other steroids if not available.
Yeah. Another questions about, maybe I'll answer that. They are looking to, whenever we have cytokine storm, we will give, some medication like tocilizumab and others, and also using dexamethasone as anti-inflammatory also to suppress the immune system. And how that come when we have a patient with cancer and they are on these medications, they will have bad disease. So why when we have the infections and we treat them with what we know that will dip the immune system lower? And I think this is what I understand from the question. There's something called the net immunosuppressive state. So a human body, they have different mechanism of immunities, and when you look to the transplant patient, cancer patients, they have more than just medication-related immunosuppression. They have others. They are already from the underlying disease. They are immunosuppressed, and that's why the problem of when we give them on this medication, they will be more immune suppressed because the underlying disease, and then when they have the disease or the infection, they will have maybe bad outcome. So there is something called the net state of immunosuppressions, and this is the thing that causing the issue. Then a question about using ceftriaxone in COVID-19 cases, maybe for you, this Dr. Noor.
I mean, if the patient, So the question on antibiotic use in COVID patient is valid. You have a patient with a viral infection and you theoretically are concerned about a superimposed bacterial infection. So what's being done right now is everybody receives this bulk ceftriaxone plus or minus atypical coverage. And I think that if the patient is severe enough to, and you're not able to clearly rule out bacterial infection, so in severe ICU admission, you could consider giving ceftriaxone or other antibiotics for the first 1 or 2 or 3 days even. But if it's clearly COVID and the patient does not grow anything on cultures, and it's important to take cultures, and procalcitonin is not, even though it's not a very, very good indicator, if procalcitonin is not going really with bacterial infection, I think I would suggest considering discontinuation early. Does that answer the question, Dr. Majid? I didn't see.
I think it's answered, but they are looking to
choice.
No, they are looking to do we need to treat acute pneumonia, viral pneumonia due to COVID-19 with antibiotics? Do we treat them as community-acquired pneumonia with ceftriaxone alone or other agent?
So there is a recent study that looked at COVID versus H1N1 and early onset co-bacterial infection in these two patient populations, and they found that early onset bacterial co-infection is unlikely. So early onset was defined in the study by 7 days. So the study was kind of reinforces that you need to really choose your patients that require antibiotics in the first 7 days if they're not a severe hospitalized ICU patient. That would be my recommendation, to be very vigilant on who to use ceftriaxone or other antibiotics with initially.
Sure. Thank you. So there is a question about any differences between collecting nasopharyngeal versus oropharyngeal sample. Is Dr. Samira still with us? Dr. Samira?
I don't think. Okay,
so I'll take that question. Generally speaking, the recommendation for most of respiratory viruses sampling that better to take a deep secretion as much as we can. If it's not, and after that it will be using nasopharyngeal or oropharyngeal sampling. Some of the kits, they have the two samplers together, the oropharyngeal and nasopharyngeal in the same kit or VTM. So we'll do both of them together. So nasopharyngeal and oropharyngeal on the same patient. We put the two probe on the same VTM or viral transmitted media and send it to the lab. And this also, the yield will be much better. So first deep secretion, then to use both of them in one VTM, which is the second to that. The third, it will be nasopharyngeal. So if I was asked to do which one, if I have one probe, I will use nasopharyngeal rather than oropharyngeal, and the difference is around 30%. I hope that will answer your question. There is another questions about Assalamu alaikum. Patient testing positive, all necessary measures done, then re-swab results negative for a few days, then tested again, become positive. What is your opinion with regards to the management of this patient? Dr. Asim? I think he's not around. Anyway, so I will answer that question. So generally speaking, we depends on time, we depends on symptoms rather than swab for recovery. So the risk of transmission of the disease, it mainly depends on the time elapsed after symptoms recovered, or from the onset of the symptom till the symptoms recovered. Generally speaking, most of the study, they're looking to 10 days from starting symptoms, at least 3 days of no symptoms, regardless of the swab results. Okay, so we need to take this equation of the swab result out. More evidence coming to shorten this duration. So the recent trials looking to 6 days from the onset of the symptoms and at least 1 day without symptoms, regardless of the swab result, regardless of either negative or positive. But these patients considered to be recovered, and if they are recovered, the risk of transmissions, it's almost nil. But with that, I think we reached with our the end of this webinar. I would like to thank the speakers for reaching this webinar, and also I would like to thank you all of patients with us. And at the end, I will just need to apologize for any inconvenience. Thank you very much. Thank you all. Assalamu alaikum wa rahmatullah.
Thank you, Dr. Marwan.
Thank you.